We're delighted to have Dr. Armin Schwarzbach with us this evening. I'm sure most of you know him. He's the founder and medical director of Armin Labs in Germany and co-founder and former CEO of the Borreliosis BCA clinic in Augsburg, founded in 2005. Dr. Schwarzbach is a medical doctor and specialist in laboratory medicine with over 3 decades of experience in clinical medicine and laboratory testing. As well as being a clinician for many years, Dr. Schwarzbach has tested over 500,000 patients now for viruses, Lyme disease, and co-infections. As well as being a specialist in laboratory medicine, he's also an expert in infectology, microbiology, immunology, hematology, clinical chemistry, and endocrinology. The subject this evening is COVID-19 and viral co-infections, and there will be the opportunity for questions in the last 15 minutes or so. So please do put your questions in both the Q&A and or the chat. And thank you very, very much again, Dr. Schwarzbach. Over to you.
Thank you so very much, Gillian, as always. It's a pleasure with you from Academy of Nutritional Medicine and for a fruitful discussion, as we did a lot of discussions about viruses before the huge virus came. So we were on the right track, absolutely. And today I want to give you a talk about SARS CoV-2 and viral, let's name it, co-infections or main infections. My name is Armin. You know me, Armin Labs, and my distributor in England for years now. We met at the House of Parliament some years ago when we had the first action for Lyme disease. In 2005 it was, so since that time we had a really fruitful forthcome in chronic infections, opportunistic infections, Lyme disease, co-infections. And now, let me say so, my favorized field the last years is the field of these viral infections. And co-infection is always a bad word. I never would name it a co-infection, also not in Lyme disease. The question is always, what is the main infection? We know that all of these patients we see have multiple infections. It's not only one infection. And on the agenda today, we have 5 different parts. The first part is about the herpes viruses, herpes virus group. Herpes viruses belong to the DNA viruses. We have on the other side, what is for me really interesting, let me say also fascinating, the enteroviruses. Let's name them the gut viruses, but they are doing much more than inflammation of the gut or leaky gut or mitochondriopathies. These are RNA viruses. In the Syncytia, I will do a summary. What are they and what are the implications? I will present you the newest Harvard study about Epstein-Barr Virus, EBV. If this could be the leading cause of multiple sclerosis, okay, I know many will say, no, I have Lyme disease, but what about the discussion to have 2 different infections together, EBV plus Lyme disease, Borrelia-Burgdorferi infection? And in the end, I will talk a little about Th1, Th2 tests and also limitations for sure, but also the pros we have nowadays by that. So let us start with the herpes viruses, the herpes virus group. Very interesting. Everybody knows now the spike protein S1. This segment infects monocytes that then act as a viral reservoir. So in a study during the COVID crisis, there was information we got that this S1 segment, it doesn't mean the complete viral structure, is recoverable from human monocytes in patients up to 15 months after their acute infection, compared to controls, and that these viruses or parts of the viruses persist in the monocytes as a viral reservoir. So the significance of these monocytes as a viral protein reservoir is supported by this data, and it depends on the S1 protein for sure, what we know nowadays. The Epstein-Barr virus, which is one of my favorite viruses long time before SARS CoV-2 came, this is acting as an inflammatory procedure response to coronavirus infection. And there came this study, I don't know if you saw that, it's some months ago now, that Jeffrey E. Gold said we run EBV antibody tests. They did the early antigen, you find it at the bottom of this information. They run the EBV antibody test on recovered COVID-19 patients compared with EBV reactivation rates of those with long COVID symptoms. And so they found out that the majority of those with long COVID symptoms were positive for EBV reactivation, but just 10% of the controls indicated reactivation. What is a control? A lot of us have chronic fatigue, or you name it, myalgic encephalomyelitis, which is ME. So this could also mean that this 10% so-called healthy group was not really healthy, because the inclusion-exclusion criteria of this study was also limited in this, but they say they are healthy. This is my hypothesis, that a lot of the ME patients have reactivated Epstein-Barr virus infections as well. Maybe parts of this 10%. But what was the main message? And I was on the track before that with my long COVID checklist. I was exactly on that way before that paper came. I said, bingo, that was my suspicion. Also from Lyme disease, I came to that point. In a subset of 68 COVID-19 patients, randomly selected from these 66.7% of long COVID versus 10% of these so-called healthy controls were positive for EBV reactivation based on the early antigen. I'm doing also a lot of early antigens in my laboratory for Epstein-Barr virus infection. The laboratories don't do it so pretty much in the world, the early antigen. So ask your laboratory or your doctor to exclude reactivation of Epstein-Barr virus. Did you do the early antigen? If the doctors are not doing, you cannot exclude reactivation of Epstein-Barr virus, as an example in ME or as a long COVID patient. Also, the IgM plays a really important role always. One of the points maybe to mention that the IgM for Epstein-Barr virus, EBV, can cross-react with Western blots up to 8% for Lyme disease. So if you have an example, as an example for Lyme disease, IgM antibodies in Western blot or an ELISA, this might not being really true Borrelia burgdorferi antibodies. This is an IgM cross-reaction from the Epstein-Barr virus infection. So they are very closely together. We named it polyclonal stimulation, also cytomegalovirus, parvovirus, herpes viruses. They all can do this IgM, yeah, let's say false positive in the case you have the suspicion for chronic Lyme. So be careful with isolated IgM. And to say this is now chronic Lyme, you need to check also the EBV or CMV or other viruses for that, for sure. So this is, I think, a huge number. If you say 2/3 of the long COVID, they suffer from EBV reactivations. And what we are doing, I come later to that, we are doing a lot of cellular tests for that with the lytic antigen. I will explain you later on for that, to find out if there's a cellular activity against EBV. This is my specialty for years now, long time before COVID, to say this is a sleeping, a snoring Epstein-Barr virus, or it's really a waked up virus being active in this patient. So there's no discussion about that. The tests we are doing, it's named the ELISpot test, EBV lytic antigen is, I think, much more sensitive than this early antigen. So and the authors, they didn't know about the EBV ELISpot. So to me, the results are missing simply. And this is an incomplete study. Also, they didn't check for the cellular immune responses in reactivated EBV infections for sure. On the other way, you can say it also works exactly the opposite way around. EBV increases the susceptibility to infection by SARS-CoV-2. Also there, you find a study here. There's one sentence I don't like so pretty much. Epstein-Barr virus, which infects and persists in 90% of adult humans. Okay, persists. Does it do any symptoms or not? We think that a lot of these ME patients of this 90%, the doctors, they say to them, you had it, but it's not active. But I'm pretty sure that a lot of these infections are really active and are doing ME and other symptoms come latent with that. So the point is that also Epstein-Barr virus, which persists or is reactivated in ME patients, increases also the susceptibility of epithelial cells to infection by SARS-CoV-2. Why? This is really pretty clear. We have three I's in all infections. We have the infection on one side, we have the immune suppression on the other side, and we have the inflammation on the third side. And this is circulus vitiosus. We have it in all of these infections, three I's, three big I's. I have also presentations about that. I'm so interested in that field. Viruses are doing immune suppression, immune dysfunction, so you need to work on it. But on the other side, they are doing also inflammation, coagulopathies. We come in the end to that point. So this is really interesting thing to bring it the other way around. So that means if you have an underlying chronic EBV infection, you have a higher risk to get active SARS-CoV-2 infection with long COVID and maybe with all of the damages after that. So this is a slide about long COVID symptoms. They correlate with EBV reactivation. This is statistically significant. And what is the main symptom? Also in Germany, I had 1 month ago, I had my own Omicron infection. I can tell you, I have also still fatigue. It's now better, but a lot of my friends and a lot of my fellows around me and employees, they still suffering from fatigue, and this seems to be really a problem. The question, is it now infection also to me with this EBV or maybe some other infections which are doing the fatigue, and then I need to work on it. Or to me, it's now from day to day better. So I can tell you exactly the story about Omicron. It was not a bad infection to me, but I'm also older. I have now gray hair. I'm not 22, and it sucks your energy away. This was for me the main problem: the muscle weakness, insomnia, myalgia. Okay, this was my problem. No confusion. Weakness is a problem for sure. I'm still suffering a little from that. Rashes, pharyngitis, a little abdominal pain. So I can confirm all of that. COVID-19 can potentially cause reactivation of Varicella Zoster virus. This Varicella Zoster virus is HHV3 virus. It belongs also to the human herpes virus group. And we have also paperwork about that patients with this long COVID have COVID infection before. They are suffering from active reactivations, Varicella Zoster virus, herpes zoster, which is also not so good to have that, because we have also studies about that Varicella Zoster virus is doing atherosclerosis, strokes, heart infarcts. There's really a huge study with 23,000 patients about this Varicella Zoster virus, chickenpox virus. So it can be reactivated, and if it's reactivated, you have a huge problem. You have, again, immune dysfunction, inflammation in your body. How can you diagnose? Come later to that. We do the IgA antibodies. IgM doesn't make such a prominent jump in the reactivations. We do IgG, IgA, and we do some ELISpots, not so strongly reacting, and then we know, is it active or not? The question we always have in the serology with the antibodies, we don't have results before this happened. So we say one serology or one antibody test is no antibody test. So we need always to follow up of the IgA, of the IgG. This depends on the half-life time. This is our own chapter also too. But this is also very important, that the reactivation of Varicella Zoster virus, it's a neurotropic virus, can also affect in neurologic complications. And then you have also the problem of concentration, memory fog. You have fatigue. They are all fatigued viruses. They all doing mitochondriopathies. There's no difference between SARS-CoV-2 or Varicella Zoster or EBV or CMV or HHV6. Also, we come in later to that. They can do neurological problems and headache, dizziness, also strokes because of this enteritis. We know that from this huge study with the 23,000. So this is really a virus which is not so funny to have a reactivation. Also, some of you know the Guillain-Barré syndrome, which plays also a role in this. What is very often forgotten is the human cytomegalovirus. We all talk about Epstein-Barr Virus, EBV, but we completely forgot about the CMV, HHV5. So we don't talk about that. Why should we forget this? The latent, this important word, cytomegalovirus, is carried by 70 to 90% of the adult population. And it is reactivated by inflammation. And what is SARS-CoV-2 doing? Also, what is Lyme doing? Inflammation. What are all of these infections doing? Inflammation, immune dysfunction. This word is missing here. Immune weakness, immune suppression, suppression of the CD3 cells. Really, really important, like an HIV patient. This is all the story of this complexity of the viruses. And this immune dysfunction is highlighted in this article. And the article said it's maybe underestimated as a driver of immunopathogenesis in patients with severe COVID-19. But I would not bring it all into COVID-19. I would bring it also in all infected patients, also patients with chronic Lyme disease as an example. They have all of these problems with immune dysfunction. This is not a problem of we are talking now about. We knew that from all of this infection, and also co-infection and yeast, mold, and all of this parasital infection. So we have that problem. This virus, CMV, other presentation I did, it's also doing non-Hodgkin lymphoma as an example. So leukemia, not panicking you. It's also cardiotropic, so inflames your heart rhythm problems. It's a joint arthritis virus. It's a gut virus. We find a lot of these leaky gut patients, colitis, Crohn's disease. A lot of these patients have cytomegalovirus in Spain and everywhere where I found that active. We can find it easily active with the cytomegalovirus CMV lytic antigen in the ELISpot, which is the gold standard in transplantation medicine. Every laboratory in university is doing that worldwide, but not for routine use for you and me suffering maybe from the existence of long COVID syndrome. Herpes simplex virus is HSV1 and 2. And in also a study with COVID-19, there were the conclusions that it shows a high incidence of HSV1 reactivation and clinically with SARS-CoV-2 severe pneumonia. These are not all patients, intensive care patients. These are also patients who were not lying in the intensive care units. Yeah, this is also one of my favorite viruses for years now, HHV6. It was completely underestimated. Human herpes virus 6. We talk about herpes simplex virus 1, 2. We talk about EBV, Epstein-Barr virus. We talk about cytomegalovirus, some of us. We forgot about HHV6. The next virus, HHV7 and HHV8. So HHV6 is now also in the focus, and there was a pilot study. Maybe some of you have heard, they investigated the active infection of HHV6 using nasopharyngeal samples from patients infected with SARS-CoV-2 with a moderate also, but to also critically ill hospitalized, and then found an impressive frequency of over 20% of HHV6 active. Though there's nothing to say more about. So over 20%, that doesn't mean that everybody is suffering from HHV6 for sure. Not everybody is suffering from Lyme disease. Not everybody is suffering from Bartonella. Not everybody is suffering from toxoplasmosis. But some of them, the question is always how many are suffering from that. But 21 is a significant number. So if you have problems still, HHV6 virus is typical ME virus, absolutely typical, and it's accepted in this world. How to diagnose? I can tell you, you do the ELISpot, the cellular activity interferon gamma release, and you do IgG, IgM antibodies. And for some, we find really PCR positive in the blood, but I'm not talking about long COVID patients, just I'm talking also about my patients with chronic Lyme or Lyme-like symptoms, about other patients coming with chronic ME. I need to come back to that because it's a chronic ME virus typically. So what about my chapter I opened before this COVID crisis? I think 4 or 5 years ago, I came over the point that we found so many Coxsackie virus infections in chronic Lyme patients and other chronic infections, or it was not Lyme disease, it was a Coxsackie virus, an enterovirus infection. And now the confirmation came also with this SARS CoV-2. I'm really happy about that the acceptance about the Coxsackie virus coming now in the focus of science by this COVID-19 story, because this is a typical myocarditis and pericarditis virus. So what does it mean if you suffer from myocarditis, pericarditis after a COVID infection? You need to be checked for Coxsackie virus group 1 and A, because they are doing myocarditis and pericarditis. The question is always, could be this reactivated, or what I postulate, we find a lot of patients with heart rhythm problems. No doctors, no the cardiologists, they don't find any reason for it, and they have underlying gut virus infection, Coxsackie B1 or Coxsackie A7 infections, and they have this heart rhythm problems. This virus is not unproblematic. It has also effects on the joints. It's not a carditis virus. Myocarditis virus, also neurotropic. So it has a high association with multiple sclerosis, also with surely ME. It's a fatigued virus. All of these patients have ME, joint problems, and a lot of these have blisters in the mouth. Blisters in the mouth. Please check them, all of them, for Coxsackie virus, easily doing IgA tests. And you see, I have some own patients coming and I always check their mouth and they have blisters, not herpes blisters outside the mouth, on the lips. They have them inside the mouth, on the tonsils, Be really careful using antibiotics. Ask them for persistent, chronic, or reactivation of Coxsackie virus A and B. So this is really infection number 1 in the world, I would say. When I diagnose patients, I would say 90% have this infection. Maybe for the Lyme community, it's not so good to hear, but this is the truth. Not so many have Lyme in comparison with Coxsackie enterovirus. They all have leaky gut, histamine, food intolerances when they come, lactose. They all have the same stories. Maybe I mentioned I had also a story with that, so I can tell you also my own story where I thought I had Lyme disease, but it was a typical Coxsackie virus infection. Because I came from Lyme disease, maybe to mention that, and I was criticized also. You're doing all into the into this envelope with Lyme disease. I say no, they have different infections. How to find out that? And then the study came. It's now over 1 year. I was happy about that study. Possible association of Coxsackie virus with SARS-CoV-2 oral cavity lesions. And this is exactly what I mentioned before. It's the same also HPV, human papilloma virus. I don't have it, or we don't have a test for that. Internationally, you can do PCR. You can try that out. It's difficult doing. But the main, what I see, is not human papilloma virus, also with sexual contacts, you know these stories. It's Coxsackie virus. And Coxsackie virus has also high association with oral cavities, also for dentists, very, very important. Also for the ear, nose, throat doctors, really important to check that. Don't forget this, not everything is Streptococcus. And this is a slide about, I think, really interesting, that you see that multiple viruses are associated with oral lesions. It's not just the herpes virus, which is primarily outside on the lips, HSV1, 2. It can be also Varicella Zoster Virus, It could be Epstein-Barr Virus. EBV also makes sore throat and makes also swollen lymph nodes. So we need also to check that point because it has this lymphotropic, maybe I forgot this word to mention, lymphotropic effects. They block the lymphatic system, they block the lymphatic flow, so patients cannot detoxify. They need some lymphatic drainage, some of them, but please also check the lymphatic status of your patient if you have some patients with long COVID. Really, really important. And as I mentioned, HSV 7, 8, we have some tests, not so good ones. Nowadays, the papilloma virus, I'm not an expert for that, but also the picorna viruses or enteroviruses, Coxsackie viruses are doing these blisters in the mouth or lesions, paramyxoviruses, measles, mumps virus. I think a really good slide for the differentials to check and to do an inspection of the mouth. And if you don't do it, you fail some clinical aspects in some patients. Coxsackie was what I mentioned already. It's a typical ME virus. Typically, it comes from the gut. A lot of or nearly all of these patients have some gut issues or had some gut issues. You get it all over the world. It's in the families. It's highly contagious. You get it in the restrooms. Like I would say, it's similar to SARS CoV-2 infection. It's a smear infection, inhalation. But now some of you would say, oh, it doesn't make anything in the teaching books. There's nothing written about it. Forget the old-fashioned teaching books. We are doing medicine nowadays, and what we see is evidence-based medicine. We have a lot of paperwork about that. A lot of you can Google for enteroviruses and ME or MS, multiple sclerosis, you will find. There is really a substantial evidence for persistent enterovirus infection. Coxsackie B1, what I found in the patients in many cases of ME, so it's absolutely typical for ME active infections. Patients with ME appears to have a higher prevalence of antibodies. The question is which antibody you do the IgA, do the IgA antibodies, then you find is it active or not. IgM will not help you, I can just do a postulation for that, forget it. Furthermore, Coxsackie B viruses can be isolated from the stool, from the feces, as well as muscle biopsy. So it can go all over your body. It's like Lyme disease. It's a Lyme disease virus. It's Lyme-like illness. Interestingly, it comes together with Lyme and co-infections in a lot of patients, this Coxsackie virus. Why is it so important? Because antibiotics don't work in this. Antibiotics will not work in this. You come, I name it a dead end. It's a one-way street. You come to a dead end. That's it. So antibiotics work for a while against the bacteria, but you provoke. You do antibiotics are chemotherapies. They suppress the immune system, and the inflammation could get better for sure. But you have always the problem if there's an underlying virus active. You will lose that therapy. You will lose that. So we need to check that. Be careful in using antibiotics. I can just say that not very often enough, because I came 20 years ago from Boroscano, Horowitz, and all of these people from islets, but now I'm completely on the way to say be careful with viruses. Not everybody has the viruses. We're doing now individual profiles. I tell you later how we're doing the individual profiles clinically and confirmation with laboratory tests. Syncytia, what are they and what are the implications? Next chapter. Also really interesting. The tendency of SARS-CoV-2 to form multinucleate cells is shared by other viruses too. So it's not just something we know from these days. It's a very old, but nobody cared for that. Nobody cared for that. Also, Cytomegalovirus is doing CMV. A lot of viruses, herpes viruses, they're doing that. They do a poly or multinucleate cell out of that, and this is really biologically active, and it makes, as you can imagine, coagulopathies, coagulation problems in your blood. This is also not funny. It's a fusion. I'm not a biologist. I can say also it's a fusion of these viruses in the cells. And this was a paper coming out April 2021. The question is, can other viruses investigate this syncytia too? Yes, they can do that. The phenomenon is well known for the DNA herpes viruses, HSV1, herpes simplex virus 1, also Epstein-Barr virus, Varicella Zoster Virus, the whole herpes virus group, Cytomegalovirus. Megalo means already that. Maybe you have now a clue. Megalo. This is a fusion of this virus of the cells, a fusion virus, which is not so good in your body. And the HHV6 induction is also in a variety of cell lines. This could also play an important role in the pathogenesis of HHV6A, not only in the lymphatic system, but also in various tissues. Don't think that these viruses are just in one tissue, and this is not the truth. And again, I think the word neurotropic came up here with the herpes viruses. So they inflame your brain and they can destroy your brain. And you need to check this also. They are high contagious, and what I see in some patients that it's transmitted from husband to husband, wife to husband. So it comes also in the families together, also to children. It's high contagious in the cellular if it's reactivate the herpes virus. And interestingly, the Parkinsonism, unilateral, also highly associated. I have such patients, and we could cure them from Parkinsonism if they had an active herpes simplex virus infection, also reinfected from their partners. So also treat the partners, diagnose the partners, because they kiss each other and they transmit again, and they are the reinfection. In this slide, you can see the cytomegalovirus, ELISpot, CMV latent. This I explain it easily. Latent means it's sleeping, it's snoring, it's not active. This is good. The lytic or lytish antigen means if it would be the other way around, this would be a reactivation, persistency, chronic. This is an activation of this human, the H is missing for sure, human cytomegalovirus. And again, what we are doing with Lyme disease for years, we did the postulation with Horowitz that we said every patient with Lyme has chronic multiple infection, and not every patient has every infection. So you have an individual profile. And the same story came up now in 2020 with the first COVID-19 studies coming up. And they said, yes, we have a lot of co-infection the same time with influenza A and B, or maybe they are reactivated with the respiratory syncytial virus. You see the syncytia, this combination, the fusion again coming, and adenovirus, parainfluenza 1 to 4, also the enteroviruses mentioned, rhinoviruses. But now for me, my aha effect, what we find with a lot of these tick-borne diseases, chlamydia, pneumonia, and mycoplasma pneumonia. And if you going back, the main problem, intensive care, is originally for sure the SARS CoV-2 virus, but later on, it's a reactivation of chlamydia pneumonia and mycoplasma pneumonia, because the patients are so reactivated and they need antibiotics in this case, otherwise they die. They are all biofilm builders, biofilm producers. A lot of slime is coming out, the aberrant forms, the cysts. We have that in this discussion. And we have a lot of these reactivation, or some name it opportunistic infection. And now you're coming back to the HRV model, which I postulate for, I would say, 10 years now. I say a Lyme patient is like an HIV patient. Borrelia is coming into your body from a tick bite, and then you're immune suppressed, and all of this cocktail is opportunistic flying around you. So Lyme is a starter. I said it very, very often before in my presentations, Lyme is a starter, but the menu is coming later on. And the menu is exactly, we are talking about that now. It could be that the tick bite was the origin of that, but later on, I don't want to go too strongly, but this is a model also. HIV virus coming into your body, and the opportunism is coming later with chlamydia, mycoplasma, adenovirus, influenza, herpes virus reactivations, and all of that cocktail is coming onto that. And don't forget the enterovirus, and don't forget the echovirus. We didn't talk about the echovirus today. It's also an interesting story. It's like poliomyelitis. Poliomyelitis, you heard about that. It's neurotropic. It makes a lot of damages in your nerve system, but also echoviruses can do that, and Coxsackie virus. Now, really fascinating, want to leave a little this way with this SARS-CoV-2 discussion. A new Harvard study came up. Is Epstein-Barr virus the leading cause of multiple sclerosis? And clearly, yes. Beneath other infections, or together with other infections, or maybe alone in a patient. The problem of this study is always the inclusion and exclusion criteria are not very well done. These authors are never checked for Lyme disease. They're never checked for Bartonella. They never checked for herpes virus. They always check for one virus. If you have good luck, and the Harvard Chen School checked also for chronic multiple infections, because we know that also Lyme disease is doing multiple sclerosis. We know that for years from Alan MacDonald, but also other infections like the Coxsackie virus is doing multiple sclerosis. We know that, but all of these groups are not bringing that together in individual profiles. We have profiles. Every patient has different profile of active infections, because not everybody has a contact to different viruses. I never had contact to herpes simplex virus 1-2, interestingly, but to Varicella Zoster Virus, my titers and my ELISpot are negative for herpes simplex. My partners or my wife's, now they were positive for that, although we are living very close together. But this is a step. It was done as the first step on the moon. This is a big step because it suggests that most multiple sclerosis cases could be prevented by stopping EBV infection. Okay, now they accept EBV could be active. Why aren't they accepting for the hell that Lyme disease is active, or Coxsackie virus is active, Varicella Zoster virus is still active? Why they say you had this infection, but you don't have it active? I never understood that the last 10, 15 years of my work. The study, interestingly, this was a huge multi-center study over a 20-year period. How did they diagnose it with the early antigen? They didn't have this ELISpot that time. They don't have it in USA. They don't have the lytic antigen. So they have a problem. So they miss also patients with active cellular immune responses against EBV, the patients who cannot produce antibodies, who have acquired secondary B cell deficiencies, IgG subclass, IgM subclass deficiencies, they cannot produce antibodies. We have also this group, or they don't do immunology. So we need, but it's better than nothing. I would not say it's a drop or not stone. They name it a milestone. I would not say this is the complete way we need to go. But they say that this 955, they said that EBV has a significant problem with multiple sclerosis. And this is what I pray the whole day, the whole year of my work with these patients for Borrelia, for Bartonella, Coxsackie. It was the first time that Vincent Marshall in the 80s confirmed that in multiple sclerosis patient autopsies in Europe, we have also the spirochetes from Lyme disease. So, but that doesn't mean that everybody has Lyme disease, okay? Not to misunderstood that point. Not everybody has one infection. They all have different profiles. So the question was also, is it curable? Maybe to use antibiotics against this. We know that we can cure multiple. My first multiple sclerosis patient I cured for now 17 years with her multiple sclerosis. She had neuroborreliosis, was not accepted correctly that time, but she got cured. Okay, so this exists. This case exists. The question: how many could have that infection? So you need to work that out. The problem is neurologists are no infectious disease specialists, rheumatologists are not infectious disease specialists. We need a very close cooperation, and we need to accept the acceptance of chronic infection is so important in this whole field. But I hope really that the way the huge virus in a very bad matter did with us in the countries, that this brings us to the way where we are going now for 5, 6, 7 years, and that we bring it more, that we say we accept the existence of chronic or reactivated infections. Now about what we're doing. The testing can be either done via antibodies, ELISpots, or PCR. Gillian, thank you so much. I did, I think, over 1 million tests, including PCR tests. We did a lot of pool tests. We do every day 10,000 or so together with these groups under my care as laboratory doctor. So we did a lot of tests, but it's not all the antibodies and it's not all the T-cellular immunity or immune tests. The antibody tests, you all know, it's Th2 tests. We call it often serology. It tests the B cellular immune responses. This depends on the plasma cells, on the stem cells. They can do also some non-Hodgkin lymphoma, you know, the B cell lymphoma. This consists of the IgG, it's immune globulin, it's a protein, the IgM, immunoglobulin M, and wherever possible, please ask your doctor, your laboratory, do an IgA test for me. This is the test I need to know, not the IgM. IgM has a very short half-life time. It can appear, it can be unspecific, can be polyclonal stimulation, as I mentioned for the Western blots. The cellular immune system completely got forgotten. Nobody checked this, also including myself. I started with that nearly 20 years ago with this interferon gamma release assay named ELISpot test. It's a so important test to check the Th1 immune system. The cellular tests are 20 to 100, 200-fold higher or more sensitive than the antibody test because 1, 2, 3 cells are enough to find out is an active infection or not. This is a technique for testing Th1 system. All belong together. So the patient says, or the doctor says, oh, do I nearly need to check ELISpot plus antibodies? Yes, you need to do it because both complement the understanding of immunology. They complement each other. So before, in every fresh infection, before you produce antibodies, you have in every time a T-cellular immune response. Yeah? The T-cellular immune response, also we have brand new papers. We will do another presentation about that. We have brand new papers yesterday that passed COVID-19 infections and passed vaccinations. We found over 1 year T-cellular immune reactions longer than antibodies. The IgA antibody for SARS CoV-2 persists longer because this is the mucosal antibody produced from the gut flora, from the mucosal membranes, or where I had my cough or so. This is a high IgA immune answer. The IgG is more systemic marker when you have systemically. So some vaccinated people, you will not find the IgG antibodies because they didn't have a systemic infection. For the vaccination, this might be a little better, but also some have problems to produce enough IgG, or they have subclass deficiencies. They cannot produce that from other infections or from birth on. So the PCR is available for all viruses. It's not highly recommended for HHV6. I would say yes, do that. You can do PCR from blisters also, or try it for HPV. That makes sense. But in the bloodstream, the frequency, the density of the molecules, RNA or DNA, is not enough to detect in this little volume of blood. So this is a longer story where I worked really strictly on it, also with a lot of attacks from colleagues, doctors on me and other specialists working in immunological tests. The ELISpot we have now for Myamotoi, for Bartonella, Babesia, Chlamydia, Mycoplasma. Other labs have it also in Germany. I'm not the only lab doing it. Also, it's spreading now around the world. The company sells readers to universities. They are doing a lot of this, so I'm a little honored for my engagement in that. I don't have anything from that, but I think it was the right track. I started with the Ehrlichia Anaplasma ELISpot, Yersinia ELISpot, EBV, Lymphatic and latent antigen, herpes simplex 1, 2, Varicella Zoster, HHV6, 7. We have also the COVID iSpot for SARS CoV-2 now we're doing successfully, especially after Omicron or past Omicron. We have a lot of these where we find a lot of high cellular immune reactions, not before, interestingly. So Omicron was a wave, also hitting myself and my wife. This is how it looks like. This is like the EBV Lymphatic antigen. This is a high active EBV infection, high active, no discussion about that. No discussion. It's not the latent phase is little there, 65. This is so high active. You need to treat. you need to treat that. This patient have this ME, they have this gut arthritis, they have neuropathies. So you need to treat this. You need to bring this lytic phase again into the latent phase, and then you have won. The patient is much better, you will see. But some persist. It's not a bad thing to have that, but it's an overproduction of lymphatic system also. Highly sensitive antibody tests are also available for all viruses. The IgA, I can pray that. You need to do the early antigen for EBV. You will miss that. The story showed that. Also for other ME and other problems. Antibody tests always ask you, I need IgA, doctor. I don't need the IgM. It's always negative. In the very fresh infection, in chickenpox, you will find that. This is an immunoarray showing positive early antigen. You find this is where the studies with the 2/3 of this long COVID is based on. They did the early antigen P138 and the early antigen P54 for IgM. This is a reactivation. It's not a past infection. This is an example how it looks like with our enteroviruses. We find so many multiple double infection, Coxsackie, echo. Not everybody has this, please. I don't want to say 99% or don't bring me to a number, but I'm specialized in that field. That's my heart, that's my specialty. So is the IgA, and if you treat, the IgA is not good. You need to treat away. What is the half-life time? It's around 7 to 10 days. So you have a high titer in the IgA, 320, that's a lot. So you need to bring it down. These patients, when you diagnose, they have it longer. you make the first diagnosis, but they had it longer. The question, how long, I cannot answer by that. There's an example for multiple sclerosis. We did tailored testing protocols for it. Borrelia illispot tickplex for the persister forms. For Borrelia, we're working with Leonard Gilbert from Uvascular University with the tested. Also some new tests are coming there now. Chlamydia pneumonia illispot, the IgA antibodies, IgA, not IgM, forget this Mycoplasma pneumonia illispot, Bartonella, Coxsackie virus, IgG. And if you do that for multiple sclerosis, and you will find not all of that active in the patients, but a lot of that. So the question is, the profiles are always a little expensive, I would say. So to me, it's better to use this AONM. It's you can download free of any cost from the AONM website. You do this so-called co-infection checklist. Patient is filling out. It's a scoring system ranked in order of priority. You will, I think, find in a lot of patients enteroviruses and herpes viruses. The herpes virus group, physician 1, 2, 3, but also chlamydia pneumonia, mycoplasma pneumonia, some have babesia, some have rickettsia. So that costs nothing. You can use that free of any cost. You don't need any test. You can work with it. But I would say, like in cancer, you need a tumor marker antigen before you start therapy. If you don't do it, you cannot compare the outcome. And this doesn't mean that every patient has active infections with that. This is a high prediction. It gives you a high prediction of the value, not to waste the money. This makes absolutely sense. We hit nearly all of that. And this patient, I would check for 8 symptoms for Coxsackie and echovirus, the stomach, a gut. I would check this patient for Coxsackie, EBV, CMV, herpes virus. I would check this patient also maybe for Coxsackie echo and the EBV, the CMV, herpes, Varicella Zoster, HHV6 is belonging to that too. And then you will find for sure some of these active. So where to find the checklist? I mentioned already, it's on the www.aonm.org. You can get this presentation. I will also spread around my therapists in my networks to Canada and other countries, because it's really interesting thing to talk about, that we are all on the right track, what we are doing. And yeah, I can proudly present that Gillian Crowther is presenting at a long COVID day program. The early bird, it's 2 days, but I really would appreciate if you get more information also from therapists. What can we do now? Treat the 3 I's, how to treat infection, how to treat mitochondriopathies, how to treat leaky gut, the energy level, Sarah Myhill and all of these specialists. And also Gillian Crowther will bring some of our aspects to that. So some of you know me. I'm coming now nearly to the end. We did a lot of presentations before crisis. So we were exactly on the right track, exactly. We said it could not be everything Lyme disease. We need to check more pathogens, and we came on the EBV, Coxsackie, echovirus story, herpes virus story, chlamydia pneumoniae. But we found these viruses really in a lot of patients. So we did a lot of these presentations in different countries. Also, Gillian supported this. I said, yes, we need tick-borne disease and viruses. Viruses will play. This was a long time before SARS CoV-2 came to us. And we did also a lot of webinars, you can see here. And as I mentioned, we have two really fascinating cellular tests now, where we have a lot of good papers, immune suppressed patients, long-standing cellular immune reactions, interleukin 2. We can do this COVID-19 testing. We do a lot of this eye spots. We do a lot of this IgG, IgA antibodies for corona, and we find simply this is how to diagnose infectious diseases. And I mentioned that already. The infection changes always the environment from anticoagulant to procoagulant. We have that in everybody. So I took my aspirin as an example during my infection. That makes sense because this infection all makes inflammation. And we have, this is a very old study, 2002, it was done by David Burke. So, and then we have the oxygen problem. We have the tiredness. Again, we have, I got cold hands during my infection. Now it's getting from day to day better. This Omicron did cold hands. I had this coagulopathy in my own body, infected white blood cells. So I'm still not fine, but let me say 95% or so on the way to recovering. But I know a lot of my friends, patients have a lot of problems with it. And coming to the end, thank you very much. And I hope for not so long, we don't have so much time, but a very fruitful discussion now.
Thank you very much indeed, Armin. Fascinating. A few questions have already come in. First of all, do you think that retroviruses or even herpes, that's human endogenous retroviruses, could be in the equation as well?
Yes, but we don't have a good diagnostic test for it. We had Judy Miklosh is her name. She developed the test, and it was taken away from her. That was in this war. It doesn't exist. Or on the other side, the question, is it really a retrovirus? I know there's a postulation also from a good friend of mine, from Dieter Klinghardt. They say it's a retrovirus. I would say it's more Coxsackie virus. It's echovirus. But they are also maybe retrovirus-like. We have perfect tests for that. They are certified, IVD registered, accredited. So we have these enteroviruses, and we are not far away, Dietrich and I, when we discuss that, yes.
Thank you. And then another question. A person who developed rheumatoid arthritis at the age of 35 after COVID. What do you think a person should test for in order to treat this? He was prescribed immune suppression shots.
Coming from Lyme disease, I would say check Lyme disease, check rickettsia. Rickettsia is a musculoskeletal bacterium. Also, if there was a tick bite, not many remember that, a tick bite. Check also for Epstein-Barr virus, for herpes simplex virus. So the whole herpes virus group is doing that. Cytomegalovirus, Varicella Zoster Virus, HHV6, not so much, but check for herpes simplex virus 1, 2, cytomegalovirus, reactivations, parvovirus B19. I forgot this. Sorry, I wanted to mention that when I went through the presentation before. Parvovirus B19 is a typical reactivated virus. We find it also in myocarditis. Parvovirus B19. Yersinia makes it. Yersinia enterocolytica. Check the IgA and the ELISpot. Check the Campylobacter. If you had swine, pork, the pork before, or swine flu. If you eat a lot of pork and burgers, check yourself for Campylobacter IgA. And yes, I would say Chlamydia pneumoniae, Chlamydia trachomatis, Mycoplasma pneumoniae, and also Coxsackie and echovirus. They are doing all arthritis. These are all arthritis viruses. Maybe we can also think about yeast and mold in some patients where they live exposure, and some parasites can do also some joint problems secondary. Maybe she fills out the co-infection checklist, and then we know, and the Lyme checklist, and we have also a parasital checklist developed.
Right, thank you. And I remember you've got a panel as well, haven't you?
We have also done a question.
Rheumatoid arthritis and fibromyalgia.
Yeah, exactly. You can do that also, yes.
Thank you. Some patients are asking about therapies for these infections. And of course, you've mentioned already the long COVID day on the 25th of March, where a lot of clinical specialists will be talking specifically about therapies and case studies. So please do come along to that. That will be many of the doctors from the British Society for Ecological Medicine, to which Armin also belongs. But one question, I'm sure you could say a few words about: how specific are antivirals, the pharmaceutical antivirals?
Yeah, this is a story where I came to Hotunia with a doctor in Australia. Hotunia is a herb. I can recommend to you, there's a book from Stephen Buhner, The Herbal Antivirals, it's named. It's so fascinating, with a lot of evidence-based paperwork. Hotunia is a typical herb the Aborigines use in Australia and in Peru. They use it in these gut infections. They use it also in arthritis, and the typical Coxsackie virus herb, as an example. Also, just to mention my favorites, what I take for years in my virus stories, and also in my COVID story, I took the Tacuna, it's named. This is a newer herb. It's not so much written in the books, but from Eva Sapi, you will find the studies about that. We have also other herbs. We could use a lot of these herbs. I can really recommend, because we need to hit the viruses, we need to bring them back to hit them on the lytic phase. We need to stop the replication of that cycle, whatever you name the virus. We have some specific herbs in the Buhner book. You will see that. If you go through it, you will see, yes, Stephen Buhner, Amazon. It's one of the bestsellers. We have also herbal antibiotics, also a really interesting chapter, but this is not enough. You always need to do a strong diet. You need to do, I name it a basic nutrition. You're not allowed to drink water with gas. You're not allowed to drink Coke, sugar. Your gut, the gut is a natural immunity. Don't forget this. Gut is a natural immunity, and the virus also is doing SARS-CoV-2, some problems with the gut. So you need a gut. You need maybe prebiotics, probiotics. You need also immune support. Maybe high-dose vitamin C, maybe glutathione, maybe L-lysine. I'm not the expert for that, sorry, but I have around 1,000 therapists. I'm serving with laboratory tests or discuss with them. And they said, yes, I'm treating immune dysfunction. I do that, vitamin C. Okay, do you treat the viruses? No, I don't know how to treat. So the herbs play an important role. We have also a new chapter, the transfer factors. Artemisia, you discuss now artemisinin, also maybe a plant, a herb, Nobel Prize winner. Ivermectin, if you have parasite, maybe an option. If you have a parasital reactivation, use ivermectin, it's successful. I'm not so sure if really ivermectin works against SARS-CoV-2. I think it works more against the parasital reactivations, but it doesn't matter because SARS-CoV-2 is not the main problem. Use biofilm breakers if you have chlamydia mycoplasma. If you spit out the slime, drink 3 liters water without gas. Yes, do a good lifestyle, no stressing factors. This can help. It's a whole treating 3 I's: infection, immune dysfunction, and this inflammation.
Oh, super. Thank you very, very much indeed. Another question is whether it's possible that someone has a positive antibody but negative ELISpot. Can that occur?
Yes, absolutely. Some patients switch also. don't want to discuss, therefore I avoided the word vaccination today. In some patients, we see overpacing of the Th2 system, overproduction of the antibodies, and cellular weakness. So they cannot produce. Then you can do the CD3 cells, CD3 plus, natural killer cells, CD56, and the CD57 cells. And then you know, so many I find with this cellular immune deficiency problem. And they had it before the infection came. And then they're blowing up all of these viruses, but nobody's checking that. The CD3 cells, they play the most important role in this. General market's not expensive. So do that, check natural killer cells, they also belong. And then you can do a therapy, as an example, with transfer factors or colostrum to support your natural killer cells. Also my example, also a little weak, so I take some colostrum, I take some transfer factors in this daily. I take also ATP fuel. It's also a remedy from America. I know for years from Lyme disease scenery. I don't want to promote anybody. There are also other products for sure, really good products, but do something which is not risky for you. It's nutritional medicine. I would not use virostatics. I would not use antibiotics in a long COVID primarily. I would first build up the immune system. I would treat the virus with natural remedies, with herbs, whatever you can use, and treat the inflammation.
Oh, thank you very much indeed. Further questions are coming in now about therapy, and I'd just like to mention that first of all, we'll have this exciting long COVID day, which is coming up very soon. And after that, we do hope to have a sort of therapy webinar as well. And Armin, you're saying so much about therapy. That's fantastic that perhaps we'll have you as well. But we didn't really plan to focus on therapy at all today. So
maybe
we'll leave those questions to the side.
Gillian, maybe to say what's I think important. If you have a Coxsackie virus infection in the gut, you cannot resorb the pills.
You can't absorb them.
You cannot absorb them. You cannot bring them into you. That's simply a problem. So if you have this active infection, the gut viruses, also Cytomegalovirus, which is a colitis virus, you have that and you don't know. You need to treat this first, otherwise, or simultaneously, otherwise you cannot absorb that. It's not coming to your bloodstream. Okay. Vitamin D, vitamin B, whatever you take, it doesn't make really a sense.
Understand, totally.
Just as a single substitution therapy.
No, absolutely.
Sorry, I interrupted you.
So we'll keep those questions that have come in about therapy, and I'm sure they'll be answered in the next few weeks. Yep. So one person is asking whether there's an IgA for Epstein-Barr virus. They're saying
I would love that. I would love that.
Antigen IgA be useful?
We don't have it.
It doesn't exist though, does it? IgA.
No, the test producers, it's good if you have the early antigen in a microarray or in a immunoblot for EBV, IgG, IgM, where they did these studies on it. The normal ELISA is really not helpful with this NTE, EPNA, it's EB and A named, and the VCA, IgG, IgM, it's not helpful. We need to do the early antigen, and much better, more sensitive is the lytic antigen in the ELISpot.
Thank you. One question here, which is a bit sort of outside the scope of what you've discussed today, but interesting. When might your lab be able to receive overseas blood work from patients not in Europe?
We are now on the CIP accreditation process, the highest qualification. Not many Lyme laboratories in America have that. I don't remember any of that. So we are doing now the accreditation, and the professors will come in a very few weeks. So we do America. We are able to organize. It's just the US. It's not our German accreditation. This is international accreditation, but not for USA. They have a special agency there. So European agency, also American agency, and we will accredit the lab also in very few weeks or very few months, and then we can also open again for US samples, which is really important because I have a lot of therapists and a lot of patients asking for that. Problematic is the logistics now. We lost now, unfortunately, we have a distributor in Ukraine and in Russia. Doing both countries, we lost now the samples, so no way. All the
Oh.
logistics is stopped. Yes, also
Oh,
for
in
all.
the Ukraine, for goodness sake. Oh.
Yeah, we didn't talk about that today, but this is where our hearts are now, together with these people. But
Of course.
okay, this is a different chapter politically. On the other side, we can transport South America now from Argentina, South Africa, whole Europe, no problem. So logistics is working fantastically. Also, after that crisis from Australia, New Zealand again, that was really a problem for us when there was no flight to that. But now we did a good revival, I would say, and the chronic infections, also including my specialty, my heart, where I came from, is the tick-borne illnesses for 20 years now. And I would say, yes, we can do it from America, I think, now in a very few months.
Thank you. Wonderful. Perhaps the last question, because I know it is after 8 already. How is it best to check lymphatic status in patients? Because you did talk about the importance of that.
Lymphatic status, yeah, it's easy. Your doctor do a palpitation of your neck and here of your ankles and everywhere where you say, oh, I do an easy question. I ask, did you have some swollen structures in your neck or your body? Is there something swollen sometimes? Did your doctor check? Then the patient said yes or no, or because it could be from time to time. It not to be a persistent situation. It depends on the immune system, on your overreaction. Some say you're a lymphotropic character, you're a lymphotropic person, so you react stronger, but maybe this could be the virus, EBV, CMV, Coxsackie, whatever, HV6. And this is a clinical sign. Also, we have an ultrasound for it. Some doctors doing ultrasound status, the lymphatic status. I was internal medicine. We did it. I was also infectious disease doctor clinically, worked with patients in therapies. So we did this. Also the lymphatic status, you can do an ultrasound, also in the deep lymph nodes. You don't taste them so pretty much.
Tremendous. That's really important, of course, isn't it, with viruses especially?
Yes.
So
yes.
I won't keep you for any longer because I know it's an hour later in Germany, but that was really fantastic. And we'll have you back on again very, very soon. I know that'll be, at least I hope so. I know you're very busy. Germany is in a very different situation to us, where we've dropped all of the regulations, or at least most of them, but I know you're in the thick of it still, and having to test some school children every single day. Incredible. Yes. But we'll, I mean, we're just very, very grateful to everything that you've, imparted today. And we'll save all of those questions about therapies and cover them again, hopefully quite soon. And we will publish the PowerPoint and also the recording on our website very soon. Some people joined late, so they're asking whether there'll be an opportunity to hear the beginning as well. Absolutely. So, Dr. Schwarzbach, thank you very, very much again, and all the very best to you over there in Germany, and hopefully the situation will resolve for all of us worldwide soon.
Yeah, thank you. I would say stay healthy, pray for a good political solution.
Yeah.
Stop that as soon as possible. And we are all medical doctors. We know what is the fate for that. And we are caring for this problem, but other problems might be more traumatic in the world now. So my thoughts are really very open with all of these people. And we need to stop the war.
Absolutely. Oh. Well, thank you very, very much, Armin, and see you again soon. And thank you everybody for spending the time with us this evening. A huge thanks. I know how busy everybody is at the moment, and very, very grateful to all of you, knowing that you're there and helping our patients.
Thank you, Gillian, for moderation.
Bye-bye.
Thank you. Bye-bye.
Bye.